Good afternoon. As a land-grant institution, we would first like to acknowledge the Gabrielino Tongva peoples as the traditional land caretakers of Tovangar, that is, the Los Angeles Basin and South Channel Islands. My name is Tiffany Lopes, and I'm the Director of Communications and Publications at the UCLA Center for Health Policy Research. Welcome to today's webinar, Selected Findings from the Final Evaluation of the Whole Person Care Program. More than 13 million Californians rely on Medi-Cal, California's Medi-Caid program for healthcare coverage. In 2016, California launched the Whole Person Care Program to improve health and well-being through the coordination of health, behavioral health, and social services for Medi-Cal patients who frequently access acute health services, incurred disproportionately high costs, and had poor health outcomes. The UCLA Center for Health Policy Research's Health Economics and Evaluation Research Program, led by Dr. Nadereh Pourat, was selected to conduct the statewide evaluation of the Whole Person Care Pilot Program. Today, Dr. Pourat will present select findings from the final evaluation of Whole Person Care, which was released earlier this morning. She will discuss some of the changes to health service utilization of enrollees and associated costs, as well as program achievements and challenges. The evaluation findings describe a major and expansive effort in California to address the needs of the most vulnerable Medi-Cal beneficiaries who are high utilizers of services. Today, we are also joined by Deputy Director of Healthcare Delivery Systems for the California Department of Health Care Services, Susan Phillip. She will discuss the relevance of the findings for California Advancing and Innovating Medi-Cal, better known as CalAIM, a multi-year initiative to initiate overarching policy changes across all medical delivery systems. Next slide, please. If you're interested in today's slides, you can request them from our communications department at healthpolicy@ucla.edu, and I encourage you to follow us on social media as well. Thank you. I'd also like to take a moment to let you know about an upcoming event. On Monday, February 13th, we will host the 2023 E.R. Brown Symposium. This year's theme, Addressing Gun Violence as a Public Health Epidemic, will bring together researchers, advocates, policymakers, community leaders, and other critical voices working to understand and stem gun violence and sharing new research and perspectives to inform policy and programs to increase public safety. California Attorney General Rob Bonta will provide the keynote address, and we've got a really great lineup of speakers from Brady, Hope and Heal Fund, the LA County Office of Violence Prevention, Urban Peace Institute, and much more. I will post the link in the chat in a few minutes for those who are interested in attending. And now let's begin today's discussion with Dr. Nadereh Pourat.
Thank you, Tiffany. Welcome, everyone. Good afternoon. We're happy that you were able to join us as we are wrapping up this extensive evaluation of the Whole Person Care Program. I wanted to quickly acknowledge all of the evaluation team that you can see here: my colleague Emmeline Chung, Brenna Amasta, Leanne Haley, Zhao Chen, Wei Hao Zhao, and Membre Haley. To begin with, we'll describe the Whole Person Care Program really briefly. It is a program that was implemented under Medi-Cal 2020 Section 1115 Medicaid waiver that allows the state to conduct demonstrations to make changes to the Medi-Cal program that would improve healthcare delivery and achieve other desired outcomes. The broad waiver aims were transform and improve the quality of care, access, and efficiency of healthcare services for Medi-Cal beneficiaries in the state. And there are two worthwhile programs worthwhile mentioning. One was that were concurrent with the program. The first one, the PRIME demonstration, occurred at the same time under the same waiver mechanism, and it was an effort to actually make changes to public hospitals in the state to deliver care to Medi-Cal beneficiaries broadly. But it does show that the effort was more comprehensive than just trying to help patients improve their health and outcome, but also work with providers of services to address issues at that end. And the second program worthwhile mentioning is the Health Home program, which was implemented under a different authority, but it is very relevant to whole person care because it was also looking at a somewhat similar approach with some differences in how to manage the care of patients who are high need and high cost. And there were distinct programs. The goals of the WPC specifically were improve the health and well-being of high-risk, high-utilizing enrollees by coordinating their care across multiple spheres of care. So not just focusing on the medical side, which may be more commonly done, but also dealing with the behavioral health side as well as social services. The specific goals of the program that were specified under terms and conditions were what you see here, included collaboration with partners, coordinating and care across the different spheres, reducing inappropriate emergency and hospitalizations, and collecting data and sharing it across partners, improving housing and health outcomes broadly. The program was implemented through 25 different pilots that operated in multiple counties. One of the pilots dropped out early because they were not able to implement the program. So 26 counties still participated. 2 of them were working together under a single pilot. As the program was requiring, partnerships were established between county agencies and a whole host of different community as well as other agencies of the county, typically led by the county health agency. I'll explain a little bit about that soon. And then an important point to remember is that each one of the pilots had while there were standardization of certain aspects of delivery, there was still plenty of flexibility given to the pilots because the needs of counties would differ, and this allowed the pilots to customize locally to address the needs of their population. In terms of who was part of the demonstration, the program language was target beneficiaries, and these included some categories that are broad, high utilizers of services, and then other categories, including those experiencing homelessness or at risk, those with serious mental illness or substance use disorders, those who were justice involved, in other words, recently incarcerated and needed specific services to transition them from the institution back to the community, and then a population that had multiple chronic conditions. These were categories that the pilots were able to choose from, where they wanted to focus their efforts. And then later on during the pandemic, another category was added, particularly focusing on individuals that were impacted by COVID, maybe long COVID or other aspects of related to the condition that might have impacted them. Quickly on the implementation timeline of the program, the very first year of the waiver was for everyone to get all of the pilots selected and onboarded, and then following that, from 2017, beginning of 2017 to the end of 2020 was the original timeline for the pilot. However, because of the pandemic, the pilot was extended for an extra year, particularly because the state wanted to transition this program into the CalAIM effort that was mentioned earlier, and that additional year allowed for that transition of services. So the time period that this current report is covering is from 2017 all the way to the end of the extension, and so we'll talk about some of those findings. In terms of how we approach the evaluation, clearly with these forms of demonstrations, it is really important to understand what was the infrastructure that was put in place, as well as what processes were followed to implement the program. So we particularly paid attention to those aspects of implementation. Then we were interested in measuring what happened to the healthcare that was provided, what happened to the outcomes of individuals and the population that received services, and ultimately, were there any reduction in cost of care, and what were the issues around sustainability? It's a mixed methods evaluation because you really need information from pilots to tell us that had to tell us what they did, how they did it, when they did it, and then use of existing administrative records, particularly Medi-Cal enrollment and utilization data, to look objectively as possible at the outcomes of the program. And here you can see all the different data sources that we use. I'm not gonna, I don't think it's necessary to explain them, but feel free to go to the report that's being released today, and you can see all of the detail about these data sources. So I'm going to cover some of the broad general findings of the program really quickly. As you can see here, the program enrolled a large number of individuals, including by the end of the program, cumulatively and unduplicated, just under 250,000 enrollees that were touched by the program. So they were enrolled at any point during the time frame that we're looking at. And so that's the green arrow, green line that you're looking at. And then down here, you can see what was the monthly enrollment over time. And you can see the growth of enrollment, and then the period of time where COVID comes into play, where the new enrollment, which are these little orange or dark red lines, that might have been impacted a little bit during that time, because some of the outreach efforts that were dependent on outreach workers going out in the community to enroll people had to be halted during the pandemic. So that impacted ability to enroll. However, there was success in continuing to enroll new individuals. And then last year, during the extension period, of course, as a lot of these activities were paring down, the number of enrollees sort of leveled off. Moving on to a little bit of understanding of how enrollment was actually, the length of enrollment, as well as whether there was churn in the number of individuals that were enrolled and then disenrolled. You can see on the left-hand side that there were about 54% that were enrolled, presumably benefited from the interventions that were provided, and therefore were later disenrolled. There were some individuals that remained continuously enrolled, most likely representing those that had the highest need, or perhaps more complex or very complex profile, and then individuals that were enrolled, disenrolled, came back more than once in some cases. In terms of length of enrollment, you have the largest population, the 38% enrolled for much shorter time than others. And you can see there's some people at the very tail end that were enrolled longer. And when you think about the target population, it does make sense that there are some individuals that really don't need extensive or long-term intervention, and some individuals do need that. Looking at what was it that was actually offered by the program, and you can see that all of the pilots provided transportation, benefit assistance, housing support, care coordination, outreach. Of these, housing support and care coordination were particularly required. So care coordination was the actual, important effort and the focus of the program and the housing support, but you can see the pilots chose to provide additional services because they mattered in order to get these. This is really reflecting the needs of the population, health education, legal services, and all of these other services. Two other ones that are worthwhile mentioning, medical respite and sobering centers, are particularly relevant to improving outcomes for patients. Medical respite to make sure that patients that, for example, are discharged are not back on the street or go home without any support and then come back to the hospital. Sobering center to reduce the need for observation of people who might be experiencing overdose and preventing them from going unnecessarily to the emergency room. Looking at the utilization of these WPC services, this is reported by the pilots in terms of who received what kinds of services, and you could see that nearly everyone, 91%, received care coordination services, and then the number of individuals that received other services is a little bit lower, keeping in mind that while it is the crucial, the main, most important element of the program is care coordination, there are still some individuals that may really not need that service. That's why you're not seeing 100% on some of these services. So it has to be appropriate to the need. Next, just the demonstration of how this massive effort was funded. That's really just to give you an idea of the program expenditures and the by pilots. I think overall amount was $3 billion to start with, and I believe, and I can get corrected later on that, but the extension was additional dollars, the extension period. And this is just FYI in terms of how the payments were made to the pilots. A lot of the payments were made in these bundles where all of the needs of the patient were provided under a bundle of services. And in some cases, there were fee-for-service payments for things like sobering centers, where it does not make sense to have a bundled payment per member per month. And then there were some other funds distributed to pilots, for example, for pay for reporting or pay for outcomes or incentives to partners, etc. More of this in the report. Please feel free to go there to get a full picture. Now I'm going to move into some of the select findings. The goal one of the program, of course, is increasing integration and collaboration between whole person care partners. This is rephrasing of what I showed you a little bit earlier, so don't be surprised if it's not exactly the same language, but just looking at how the partnerships were developed under the program, you can see that pilots pulled together a total of 543 participating organizations, and it ranged between pilots. Some pilots had more, some had fewer, but in terms of their involvement, the great majority were very actively involved, participating in planning and implementation, and some had less involvement, but that really has to do with what kind of organization they were. This one just shows you that there were two types broadly: community partners and county agencies. You can see the breakdown of county agencies, and 58%, the majority, are actually community partners. And you can see here what type of community partners were included. And again, when you think about why these type of organizations are included, it is really to do with what were the needs that the pilots need to answer. For example, social service partners and housing and homeless support services, etc. In terms of this is from the qualitative findings, when we actually talked to all of the pilots about what were the elements of success, or just how they did things, the points that really stood out to us. If you want to have successful partnerships, that are engaged. You have to have regular communication. You may want to do, specific case conferencing so that you actually can focus on the needs of patients that are perhaps unique or need to be customized, and also making sure that you provide incentives for participation and data sharing, particularly because a lot of social service organizations may not have the infrastructure to do that kind of work, and data sharing is crucial in this under this program. So goal 2 was indeed improving data collection and sharing among WPC partners. And when we looked at the information that was available to us, one of the most important things that they did, because none of these organizations are, on single data sharing platforms to start with, it was really important that there was a universal consent form that was established so that administrative burden is reduced as much as possible. Having a memorandum of understanding, having business associate agreements with key partners to smooth out. Those were other strategies employed, having electronic management platforms, particularly for care coordinators who had to know what's happening to the patient. Are they in the emergency room? Are they where are they and what they need and how their care can be managed, and then providing real-time alerts. Those are some of the important strategies that were very relevant and needed. We looked at all of the, what the pilots reported in terms of challenges and successes, because a lot of this effort had to be done from the beginning of the program. A lot of these things didn't exist. So not being able to get the necessary data, getting buy-in from partners, and implementing those systems were significant challenges. You could see a lot of pilots reported those, but then you can see the successes were just about everybody was able to find a way to overcome those challenges. Moving on to the third goal, which is increasing coordination of data for high-risk, high-utilizing beneficiaries. One of the really important aspects of this program is that you had to establish multidisciplinary care coordination teams. You had to have people with different levels of expertise involved in these care coordination teams in order to deliver what was needed. Housing navigators, social workers, nurses. One of the really interesting features was employment of community health workers or other staff with lived experience, people who had been there and could understand what happens, for example, if someone is just released from the jail and what they need. How do you connect with them? How do you help them? Just transition them immediately into the services that they need or into help them get housing, etc. And then you can see that the caseload varied quite a bit. Average was about 25 per enrollees, but it really depended on the level of need of the individual. Moving on to some of the frequency of different care coordination strategies that are really important. I just mentioned the importance of warm handoff, importance of providing transportation to individuals that really need that service to get to the care that they need, co-locating mental health or housing staff. For example, one of the counties had a staff person at the jail so that they can actually identify individuals that are being released and help them right then and there. Using tiers of care coordination to match the level of need based on intensity. These were really important strategies that are mentioned. So moving on to the fourth goal, speaking really quickly, we have a lot of material. I do apologize. Hopefully we can deal with some of these in Q&A, or feel free to add questions and you'll get some answers. So the fourth goal was increasing access to care, reducing emergency department or ED and hospitalizations. So just to tell you what is the methodology, it's a little bit complicated and I want to make sure everybody can follow, is here is an example of how did we measure changes in ED utilization in a way that actually shows the benefits that are really due to the program as opposed to what might have happened naturally in the absence of the program. So we did select, we have the enrollees of the program, we identified a control group that are very similar to the enrollees, except for the fact that they were not enrolled in the program. And we looked at the trends in utilization over time. In this case, we were looking at ED visits per 1,000 beneficiaries per year. And you can see we were looking at trends 2 years prior. So this is our intervention group, I believe, the enrollees. So you look at the trends, what was happening before, what happened during the program, and then same trends for the control group presented by the green bars. And then we measure what was the difference in the pre-period for each one of the groups, what was the difference in the post-period for each one of the groups in this case, in these two numbers. And then we compare the change that happened for the enrollees, the change that happened for the control group, and measure the significance of that value to see if this was truly a significant difference between the two groups, patterns between the two groups. So moving on from that, these are some of the high-level findings. Our findings in the report are more. Please go ahead and look at those. We are just showcasing some of them that stand out. There are 45 fewer hospitalizations and 130 fewer ED visits compared to the control group. So these are in addition, above and beyond. And also an increase in substance use disorder services and specialty care services. So some meaningful changes in the overall pattern of care. We also attempted to measure the amount of potential savings to the program. We really are not able to look exactly at all of the program expenditures, but what we were able to do was to look at the claims and attribute a dollar amount to those claims, therefore what we estimate to be payments for the program, and then measure changes in payments. So we looked at changes in outpatient, and you can see a decline, changes in ED visit payments, hospitalizations, and also we looked at outpatient medication. In this case, there was an increase, and an increase in some of the residual services, excluding long-term care, that did not change. The overall amount that we estimated was declined per beneficiary per year was $383. Please don't try to add these numbers together because these are estimated a little bit differently. This is the overall amount. The other important thing that we needed to understand was, well, what is were there any subgroups of patients that may have benefited differently from the program? And what we did here is look at the level of complexity of the individuals. We separated those who were medically complex or were at risk, but their care was not complicated by substance use disorders, severe mental illness, or experiences of homelessness. So when you compare the two populations, you can see that indeed both of them, both categories experienced fewer ED visits, fewer hospitalizations, and a decline in expenditures. But when you compare the amounts, you see that for those whose care was who were very complex, they had all of these other conditions in addition to potentially being medically complex, there was a lot of decline in ED visits and decline in hospitalizations, but the amount of dollars that were declined was a little bit lower than the group that were medically complex. And this makes sense because there are individuals that have these kinds of complexities are more likely to go to the ED or end up in the hospital, sometimes without needing a lot of intervention. So there are some individuals that may be in the ED because they are seeking shelter, or they may have overdoses or other kinds of conditions that don't require a lot of intervention, compared to individuals on the right-hand side here that may need a lot of intervention because they're so complex. And even though there was the reduction in the number of ED visits and hospitalization was not as great, but the amount of expenditures for those individuals was larger. And so very briefly, because before I hand it over to Susan Phillip, is what happened following this demonstration. As you know, all of these pilots have been transitioned to 2 new services under the program. I'm not going to get into the detail of those, but I think the most important thing that I think is worth mentioning at this point is that you really need to look a little bit below the surface at the characteristics of the population that receive these kinds of services and figure out whether or not you want to modify the program to address their needs better. Susan?
Great, thanks so much. Good afternoon, everyone. I'm Susan Phillip, Deputy Director for Healthcare Delivery Systems here at the Department of Healthcare Services. Before I kind of get into these slides, I just want to take a moment to acknowledge the hard work of the team at the Department of Healthcare Services who really oversaw the whole person care program over the 5-year of the pilots, and of course our whole person care lead entities and their partners who did the work and really brought their passion and commitment to serve the target populations. And I also just want to thank, of course, the UCLA evaluation team for this really robust and independent evaluation. It's really great to see this evaluation so we can learn from the whole person care pilot efforts in the systematic way. So I wanted to cover CalAIM and really specifically hone in on the couple of initiatives that Dr. Pourat had flagged already related to ECM and community supports. And I also wanted to talk about PATH, which I'll talk about in a little bit. So I do have quite a few slides. I'll try to go through them at a reasonable pace and leave some time for questions. Okay, we can go to the next slide. Okay, so we hear this acronym CalAIM, and that stands for California Advancing and Innovating Medi-Cal, as many of you know. So this really is building on years of investment and experimentation through these pilots and really drawing on lessons learned. Just the idea is that it's really our effort to fundamentally transform Medi-Cal and really moving from this notion of a healthcare system that focuses on a traditional healthcare provider, working in their silos, to really thinking about, partners in the community that are really needed to engage to serve our Medi-Cal members in a holistic way. So really, how are we engaging community-based organizations and our social services partners to really deliver that whole person care set of services? So it's really trying to take, the successes of these pilots and scale it statewide. Okay, so we can go to the next slide. So as Nadereh mentioned, we do have the notion of CalAIM, again, is to build on pilots and the lessons learned. So we talked about whole person care, of course, and Nadereh alluded to the health home program, which also ran in parallel. And so both of those were really key foundational pilots that we learned from to design CalAIM. And you'll see certain themes from the findings that we heard as part of the whole person care demonstration that you'll see reflected in the way we design ECM and community supports. You'll see that in the next few slides. So let's go to ECM. and community supports. And this is just a high-level overview of what this is. So this was really launched under CalAIM. So CalAIM, just for context, we had there was a Medi-Cal 2020 waiver and CalAIM, the new waiver, which was approved in December of 2021, runs for 5 years, and that is where we have our CalAIM initiative. So it's under the 1115 demonstration as well as 1915B waiver have components of CalAIM. ECM is really a new Medi-Cal benefit under CalAIM designed to support this comprehensive care management for members with complex health and social needs. So, we're talking about folks with high needs that often must engage with multiple, delivery systems to access care, primary care, specialty care, dental, mental health, substance use disorder, long-term services and support. So really, folks that need that high touch and really high touch and in-person set of services to help them navigate the system. ECM is really intended to be address both clinical and non-clinical needs. So I do want to emphasize that point. And again, it is really intended to be high touch and meet the members where they are, right? Whether they be in their homes, whether it be in their residential facilities, in their doctor's offices, if they're homeless on the streets. So it's really intended to be high touch and meet the members where they are. And then I also do want to point out that ECM is actually part of a broader population health management strategy under CalAIM, which I'm not going to get into, but the whole notion of the population health management strategy is to really design care management interventions to meet the needs of the members. And ECM is for those individuals that need that really that high touch and have those intensive care needs. So community supports refers to a set of services designed to address social drivers of health and advance health equity. I'm going to get into a lot more detail of what that means. And these are services that are considered medically appropriate and cost-effective alternatives to medical services. Okay, so we can go to the next slide. I'm going to switch back a little bit to ECM really quickly. And I talked about a few aspects of ECM that you see on this slide. But I do want to point out these few core services that are foundational to enhance care management. And these are services that ECM providers have to be able to provide in order for them to be considered ECM providers under the Medi-Cal program. So this includes outreach and engagement, includes comprehensive assessment care planning. It includes enhanced care coordination, not just among healthcare services, but also among social services and social services and supports. It includes member and family supports when needed, health promotion and education, really to enable members to engage in self-management. And finally, a comprehensive transitional care, which would occur, when a member, an individual is really transitioning between healthcare settings. We can go to the next slide. So as I mentioned, ECM is really intended to focus on individuals with high needs, and we're calling that the set of populations that are eligible populations of focus. So you'll see a lot of the same themes that were in the target populations that the pilot programs had designed. And what we, in designing ECM under CalAIM, we really took a phased-in approach. We knew that, we couldn't just have everything go live all at the same time. I really needed time for our delivery system to build up capacity and to build up that infrastructure and capacity to address the needs of the different populations of focus. So the first set of population really to go live is under, as Nadia mentioned, the whole person care and health home counties. Those went live January of 2022. And those for individuals that and families experiencing homelessness, folks considered at high risk for avoidable hospitalization and emergency department utilization, so high utilizers, and then individuals with serious mental health or substance use disorders. So those are the folks that really went live January 2022. And then for the whole person care in health home counties, and then went live statewide July of 2022 for those populations. And then January of 2023, the populations of focus that just went live are individuals, adults living in the community who are at risk for institutionalization. So these are folks that could be at risk for long-term care in nursing homes. But, if they are provided that enhanced care management, they could reside within the community safely. So that's one population of focus. And then there are the other one related are individuals that are residing in nursing facilities, but could safely transition back to the community. And so that's another population of focus that went live January of 2023. And we are targeting this coming July, children and youth as a population of focus. So these would include children in who are welfare involved, such as children in the foster care program and children with specific chronic conditions and high needs. And then we have populations of focus coming live January of 2024. So this includes individuals transitioning from incarceration statewide. As I mentioned, this population is a sub for those that were already doing this under the whole person care counties, but it will be statewide come January 2024. And then we also recently included a population of focus related to birth equity to really drive our comprehensive quality strategy to really reduce disparities for certain populations that have evidence of birth outcomes and disparities. So that's another population of focus that we're currently designing and will go live in January of 2024. Okay, so we can switch. So this is just a visual to show that when the counties went live in 2022. And so, yeah, we can go to the next slide. So I wanted to focus on community supports now. Community supports include 14 pre-approved set of community supports that managed care plans are encouraged to, but not required to provide. And what does that mean? So ECM, I should point out, is a benefit under the Medi-Cal program, and managed care plans are required to provide that for our Medi-Cal members that are that receive Medi-Cal through managed care, which is over 90% of Medi-Cal beneficiaries do receive Medi-Cal through managed care in the state of California. So ECM is a benefit, whereas community supports is, again, managed care plans are encouraged to, but not required to provide that at this point. So these are considered, again, substitutes for utilization of other services or other settings, such as hospitals and skilled nursing facilities, set of services, or emergency department use. From the findings that Nadereh presented earlier, you saw that one of the findings was a potential reduction in emergency department use. So in us selecting which community supports can be provided under CalAIM, we really took a look at those services that could be considered to be a substitute for other healthcare services. So for example, recuperative care, also sometimes referred to as medical respite care. So that could really help folks who, for example, who might be in the hospital, may no longer require hospitalization, so they could be discharged, but they still need time to heal from their injury or illness, but maybe they don't have a living environment that's stable or safe. And because of that, it could exacerbate their condition. So providing that recuperative care could reduce unnecessary length of stay at the hospital and then still lead to better outcomes. So that's an example of how a community support could lead to substitution of certain services. So I'll just go to, I see the time, so I will move it along. We can go to the next slide. So these are 14 the services that I mentioned that are approved. The links here provide a lot more detail of what these services are, who's eligible, and further guidance on that. As I mentioned, that plans are not required to, but may offer these, and we have seen take up across the state by every managed care plan to offer some community supports in all counties. So the ones that we have seen quite a lot of take up is medically tailored meals and medically supported foods, and the housing suite of community support services. Okay, now we can switch gears here. So, as I mentioned, this is a lot of services that we are wanting to encourage the delivery system to offer. We want to ensure that the delivery system has time to build up capacity and infrastructure. And we know, it's not going to all happen on the same day, and there really needs to be that phased in approach. So what we have done here is create a program called PATH, stands for Providing Access and Transforming Health. And it's a 5-year, $1.8 billion initiative to really build and scale the capacity necessary to ensure successful implementation of CalAIM, and really maintaining also the infrastructure and investments that have been built under whole person care as well. So we intend these dollars to flow directly to community-based organizations, providers, county agencies, local governmental agencies, tribes. So this is really intended to build capacity directly to providers. We can go to the next slide. So this slide provides a quick overview of the key initiatives under PATH. And I'll just walk through this slide, and then I think we'll pause after this. I have several slides after this that provides a deeper dive into each of these key initiatives, and also provides links so you can go to our website and learn more about each of these initiatives as well. But I do want to flag a couple here. So collaborative planning and implementation. So the notion here is that there are dollars under PATH that are really intended to support regional collaboratives. So collaborative planning and implementation groups at a regional level, which could include managed care plans, providers, community-based organizations, counties, public hospitals, tribes, really anyone that's interested in really promoting readiness for enhanced care management and community supports. So we, DHCS, working with our third-party administrator, has identified facilitators in the different regions, and those facilitators have been selected. And now we have kicked off the regional collaborative planning efforts just in January. So if you're interested, you can go to our website and register to be part of the collaborative planning initiatives. So you can just register, provide some high-level information, and then if you want to sign up for a specific one, you will get more information on that, or we can match you to one in your local area. So the next initiative is called CITED, which stands for Capacity, Infrastructure, Transition, Expansion, and Development. Easy to remember the acronym. So these are dollars that are really intended to be provided directly to organizations that are looking to build infrastructure and capacity. It's application-based, so we had a pretty detailed application. There's strict rules on what the dollars can be used for. It really has to be tied to building capacity for ACM and community supports. And so we received a number of applications. this last round, and we just announced the first round of awardees just 2 weeks ago. So you can go to our website and check that out, but we just awarded $119 million to 98 organizations statewide under round 1A. And so there'll be multiple rounds offered through 2025, and there will be additional opportunities for applications for organizations interested. And the next initiative I wanted to make sure folks were aware of is a technical assistance marketplace. So, you know, we've heard a lot about the need of organizations to understand, say, for example, how do I contract with a managed care plan? You know, what are the billing systems that's necessary? So all of those types of questions and that technical assistance, those will be addressed through TA marketplace vendors that will be available in the TA marketplace. So that website just went live January 31st, 2023. So just a couple of weeks ago, and we have TA vendors that DHCS and our third-party administrator reviewed and approved. Organizations that are interested in finding that technical assistance can go take a look, and there will be an opportunity to develop projects and then request funding to support those TA specific projects. So please check that out. And then, of course, I do want to just also share that there is a justice involved capacity building funding under PATH. And this is really designed to help our local partners, sheriff's departments, and jails, organizations, counties, et cetera, that are looking to build that infrastructure and capacity to build that pre-release enrollment and suspension process. So making sure folks stay on Medi-Cal, and that there's the IT infrastructure and data exchange infrastructure that's really necessary to maintain that. So there's funding available to build up that capacity. And there's also dollars available to really build out a suite of justice involved initiatives under CalAIM as well. So that's the quick version there. Again, more information available in the slides here, and can go to the website that'll provide additional information. Feel free to send questions as they come up. And so with that, I'll turn it to Tiffany.
Thank you so much, Susan. And thank you both for a very thorough presentation. I don't know if you can see, we have a lot of questions that are coming in the Q&A in the chat. We have some folks from the evaluation team that are going in and answering some of those questions, but let's get through some of these. We've got about 7 minutes, so we'll try to get it done quickly. Are there any plans to publicize CalAIM benefits to public health departments beyond behavioral health programs? This person says, I work with communicable disease programs, and so far no one I've talked to in numerous counties have heard of CalAIM. Many clients they work with diagnosed with communicable diseases intersect with the populations of focus for CalAIM. What is the best way for public health staff to connect their clients to care? Medi-Cal eligibility workers, MCP contacts, local providers.
Yeah, so certainly the managed care plans is definitely one. You know, so again, our Medi-Cal members are tied to a managed care plan in the region. So the managed care plans are really supposed to be the first point of contact. So I'd really encourage reaching out to your local Medi-Cal managed care plan, and that organization, that entity being the first point of contact. But it's also, you know, in terms of if you're looking to understand further information about PATH or some of the other initiatives that, you know, can certainly come to DHCS directly for that. Because again, we are looking to build capacity at the local health jurisdiction level. So for example, if a local health jurisdiction is looking to become an ECM provider, that's an opportunity that could happen now, and that would require direct contract with a managed care plan. But so that's another opportunity to engage.
Thank you. Will the Technical Assistance Marketplace Initiative provide MCPs with tags for compliance/audits to monitor requirements?
The TA marketplace is really, the audience is really our CBOs, providers, and organizations that are looking to contract with managed care plans. So the audience is really providers, not managed care plans. I did not talk about the other initiatives that are really targeted towards managed care plans. There's incentive payment dollars that go to our managed care plans to help managed care plans build up capacity for CalAIM directly. So those are dollars that flow directly to managed care plans. But in terms of technical assistance to managed care plans, we have a lot of guidance to our managed care plans on our website, everything from, what billing requirements are, coding. So there's quite a lot of information that we have developed, but if there are specific gaps that you're finding, please do share with our team.
Yeah. Can you talk a little more about individuals experiencing homelessness or at risk of homelessness? What kind of housing support services were offered, and was it successful?
Nadia, do you want to take that for the pilots?
I'm wondering actually if Brenna or Leanne can speak to this in terms of the details of the housing support services. I mean, generally, most of the effort was concentrated on trying to identify who needs it and how to link them to different providers. Brenna, did you want to expand on that, or Leanne?
Great. So Whole Person Care did not provide direct housing funds, but they could have provided funds for first month's rent, security deposit, helping with any move-in cost, furniture, things to make people feel more comfortable. There were a lot of housing navigation services, making sure that people were connected with the correct types of housing. So maybe if they had a disability, making sure that they had accessibility in their housing options. Overall, I would say, pilots felt that they were able to make some successes in this area.
Thanks, Leanne.
So this is a two-parter. This person says, thank you for sharing about this comprehensive evaluation. Were economic evaluations such as a social return on investment analysis also conducted to better understand the value of investing in the social determinants of health in a coordinated way? And then was health equity explicitly measured or operationalized, such as by using any equity indices or frameworks?
Right, so the answer is no to both of those at the time. Remember, our effort started way back in 2016. So at the time, we were not required to do a return on investment analysis. I think there's a lot more needed to do that kind of work. And our data, we were relying primarily on the administrative data that are not the best source for that kind of analysis because they have limited information. And then we also did not do analysis by race ethnicity. For example, under this particular evaluation, that was not our charge. That, as I understand, is definitely an area of interest for the state. Moving forward, we have done some other analysis with a subset of the population. We had an earlier webinar this morning with RWJ that's going to be available and provide some evidence of potentially differential impact or how the program might have addressed racial ethnic disparities in access and use of services. I encourage you to seek that particular report out, but we definitely are interested in looking a little bit more in detail to see whether everybody benefited the same, or were did different groups benefit in different ways from the interventions.
Yeah, and I'll just add that that is definitely it's a great question, and something that we are as a department interested in looking into. So as we have you know, now scaling these services and benefits statewide, we're looking specifically, for example, at utilization reports and looking to see how we can cut the data, for example, by demographics and really being able to, you know, drill down into that. But it's a great question. So that's part of questions that we're looking at in terms of how we're collecting data moving forward and how we're analyzing it as well.
Thank you both. Unfortunately, that's all the time we have for today. We still have a ton of questions. So if there's something that you do want us to get answered, if you can just email us at healthpolicy@ucla.edu, and we'll try to get your question directed to someone who can help. Again, if you want a copy of the presentation or a link to the YouTube recording, you can also email us at healthpolicy@ucla.edu. I just want to thank you all for attending this month's webinar, and thanks to the presenters. I hope you have a wonderful rest of the day.